Thank you for presenting the three types of stains that you use in pathology to evaluate for the presence of amyloid fibrils in biopsy specimens. I just wanted to know what the relative sensitivity and specificities are for those three stains and why Congo red seems to be the primary stain that you use. But then you presented Alcian blue and trichrome as well.
Yeah.
So do you do all three at Mayo, or do you do Congo red, and if it's non-diagnostic, then you'll proceed to the other ones, or how do you decide
That's
that?
a great question. So we will do Congo red and sulfated Alcian blue on all of our suspected cases of amyloid. Trichrome is a very common stain that's present in every lab. It's usually used for other things, just looking for fibrosis. And so if I'm suspecting light chain, I will add a trichrome. One of the reasons that we do the sulfated Alcian blue together with the Congo red is well, it's not entirely specific and sensitive for amyloid. It can help highlight very focal amyloid, especially if you have like interstitial amyloid or very tiny amounts. But not most labs don't have sulfated Alcian blue. It's not as common a special stain to have versus Congo red. You're pretty much going to find that across all of your labs. So Congo red is still going to be the most sensitive and specific stain to use.
Because I mean, it looked on the slides that you showed us. Maybe those were very significant cases, but
yeah,
that sulfated Alcian blue looked like it was more sensitive because it was lighting up the whole slide. And in those same cases, when you showed the Congo red under polarized light, I was only seeing a little bit
right.
of apple green birefringence.
So you can sometimes see fibrosis and other things staining depending on the quality of the stain. So it's not as specific. Okay. So using them in tandem has served us very well, but really the Congo red is the primary one that you need. But I get what you're saying, but most labs don't have the sulfated Alcian blue. Okay. But we do a lot of amyloid detection and testing at Mayo. So I don't know if you had
just I would say I'm in Mayo in Rochester, and our cardiologists prefer the sulfated Alcian blue. They actually will do Congo red sort of secondarily. From my lab, we actually like the Congo red. So it's a little bit of preference and what you're used to looking at. I think there is this issue of possibly too much sensitivity with SAB. You get some false positives.
But who is driving the test at Mayo? Is it the cardiologist or the pathologist?
I'm sorry, our cardiac pathologist. Our cardiac pathologist. I'm sorry, I misspoke. Our cardiac pathologists prefer the SAB. I'm sorry.
No. It's really a Mayo thing. I don't think I've ever seen sulfated Alcian blue come from anywhere else.
And I have a specific question on that test, and it relates to fat pad biopsies, for which, in my experience, we've had some, I would say, low detection rate. Very negative. So often we've had negative testing. I don't know how you're doing at City of Hope. Would sulfated Alcian blue be useful, really, for fat pad biopsies as a screening more than Congo red?
I think it can be very helpful if you have it. But again, it's variability of it being available in your lab.
And why does it have a limited availability? Is it because pathologists are not experienced with it, or are the reagents difficult and unstable, or what is it?
That's a great question. I don't have an answer to that. I think there's not too much other use for it. And again, as Dr. McPhail mentioned, there are false positives that you can get with it. And so really Congo red is kind of generally considered the gold standard, because if you do see that apple green birefringence, in almost all cases, you can very confidently say that you have amyloid deposition, which is not always the case for the sulfated Alcian blue.
Hi, thank you so much. This is such a wonderful presentation. So Dr. McPhail, we are doing this lumbar spinal stenosis study together. We're basically looking at, it's led by Matt Maurer at Columbia, where we're looking at spinal ligament samples and staining for amyloid or for Congo red to then identify amyloid, send for mass spec, and then potentially bringing those patients back to see if they have cardiac involvement. But we have a fair amount of patients who have this indeterminate mass spec. Does that mean that they had the amyloid, those three proteins were positive, but then we didn't find a specific etiology or specific precursor protein identified? And how often do you see that?
That's a really good question. So this is something we really don't see very often in other tissues. That it is not uncommon in spinal stenosis specimens. It's pretty rare anywhere else. So what it means is you have the amyloid signature proteins. So proteomically, you're convinced it's amyloid, and you really just don't have a type. I actually think they're all going to turn into TTR eventually, which is kind of the backwards of the way we think amyloid works. But I think they just haven't grown up to be TTR yet. So that's my suspicion. It's hard to prove it. It would be really nice to have a case to, to see over time and see how it progresses. But I don't have an example of that yet. So I think it alarms people because it makes them worry that it's some other type altogether. And it probably really isn't. I think it's just a very early, incipient, whatever, nascent form of amyloid, and it hasn't so-called grown up to be TTR yet.
So I have a question. Obviously, in my practice, mass spectrometry is a gold standard, but there are cases where I'm wondering really whether concordance or other tests are enough. And I just saw a case this week. A patient with a known IgG kappa MGUS, progressive renal failure. And she had a kidney biopsy, which shows really amyloid involvement. By immunohistochemistry, it is kappa. But her kappa-free light chains are negative. So in that case, I would say there is a good concordance between a small M spike and the presence of Congo red positive material in the kidneys. In such a case, is concordance enough, or would you still require a mass spectrometry?
The mass spec. That's an interesting question. So did you say it was immunohistochemistry or immunofluorescence?
Immunohistochemistry.
Okay, so we're still a little worried about immunohistochemistry. Immunofluorescence in kidney is actually a very good test, partly because we don't see TTR in kidney, so that is not an issue in kidney. So immunofluorescence is pretty reliable, but what you're describing is a little bit weird. So I think anytime things don't fit, it's not a bad idea to do a confirmatory test.
Okay, thank you.
Any other questions? Thank you so much.